Here we go.
Good morning, everyone, and happy Social Work Month. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador College of Social Workers. I will be your moderator for today's education event, Ageism, Individual and Collective Opportunities to Change the Conversation. The webinar presentation will be approximately 60 minutes, followed by a 30-minute question and answer period that I will moderate. And throughout the presentation, I encourage you to type in your questions using the question mark widget to the left of your screen at any time, and I will begin asking them at the end of the presentation. The recording of this webinar will be available on demand in the coming days and on the college's website under the Continuing Education tab. I now want to introduce our speaker, my colleague, Henry Kiley. Henry is a registered social worker with the Newfoundland and Labrador College of Social Workers. He has a BSW and an MSW from Memorial University. Henry spent 10 years of his career with Eastern Health working frontline in mental health and community supports, but mainly in the area of long-term care. Henry managed the long-term care single entry program for a number of years before joining government in 2010. He has been with government since that time, with the exception of a year spent as a manager of social work and spiritual care in a long-term care facility in Manitoba. He now works as the Director of Seniors and Aging Division of the Department of Children, Seniors and Social Development, as well as Provincial Director of Adult Protection. I'm also pleased to note that Henry is the 2023 recipient of the CASW Distinguished Service Award for Newfoundland and Labrador. Henry, I'm really looking forward to your presentation, and I'll now pass the virtual podium over to you.
Excellent. Thanks very much, Annette, for the kind introduction. And good day, everyone, and welcome to the webinar. I want to start by saying a very happy Social Work Month and greetings from the East Coast. And I hope during Social Work Month that you're taking some time to take some time for self-care and actually enjoy yourself during the month. So our proposed agenda for our time together today, just want to make a few acknowledgements. We'll talk about some perspectives and impacts of ageism, some perceptions of age and aging, and what are some policy responses that are happening to age and aging. I'll give some examples from the province here in Newfoundland and Labrador. We'll talk nationally and internationally as well. And then what are some opportunities that we have, again, both individually and collectively to address this issue. So I guess the first acknowledgement I need to make, spoiler alert, I'm not a senior or an older adult, but I am aging. And the fact of the matter is that all of us are. And if we do it long enough and well enough, we can experience healthy aging and we can be seniors and we can thrive in later years. So want to also acknowledge, again, that a lot of the perspectives I'm going to share come from my experiences in the field, both frontline, working in management positions, in policy, but most importantly, working with older adults directly and those who support older adults and learning a lot along the way. One of our first acknowledgements that we need to make is the fact that ageism is a human rights issue. Much like any other ism, it gets minimized a bit, but and we'll talk about the serious impacts of it as we go along, but any type of discrimination is a human rights issue, and ageism is nonetheless. So I think it's important to put that lens on it when we talk about and people's experiences of ageism, and when we hear about experiences of ageism in our practice. Ageism is also a lifespan issue. In the literature, you see reference to ageism and reverse ageism, depending on the cohort that it's aimed at. But ageism is ageism, and it's discrimination against any cohort based on age. I think most commonly we relate it and we think about it as directed towards older adults, and I think that's a bit of a safe assumption because for the most part it is. I remember personally, my first experience of ageism was actually as a new BSW grad, being asked in one of my first work placements, "Aren't you a little young to be at this?" I think that's an experience of ageism, a mild one, but an experience nonetheless. Healthy aging is a human success story. I think it's important to acknowledge that we're living longer. And the issue often comes down to the quality of life that's in those years. But we think back over the development of ourselves as a species, our life expectancy has increased quite a bit. And that's due to better knowledge, better healthcare systems. We're better able to take care of ourselves and make more informed decisions. But aging, of course, is not always looked at as a human success story, hence our conversation today about ageism. So either way, there are positive and negative, perceptions of older adults that we'll talk a little bit about. We've been talking about ageism for 50 years. I think it's also important to acknowledge that. It's not a new issue. In the literature and in practice, in some way, shape, or form, we've been talking about it for a long time. And again, it's not the only ism that we have been talking about for a long time, but it's certainly been in the vernacular and in our practice for a long period. I think it's important to acknowledge that ageism is one of, if not the last form of socially tolerated discrimination, misunderstanding, hate, and violence. I was going to say socially accepted in there, but I'd like to think that we're moving away from the concept of it being accepted, although it's still alive and well in everything from our systems to our birthday cards. I think it's easy to find examples of ageism. We do need to acknowledge our individual and collective responsibility. I think particularly as clinicians, as social workers, as practitioners in various fields, even if we're not working directly with older adults or in the area of long-term care or continuing care, we will and we are working with older adults. We're working with intergenerational families. We're working with single older adult families. And it's important, I think, again, as social workers, that we're aware of our own impact in that relationship and the individual responsibility we have as a practitioner, but also as a human being, to be aware of some of the biases that we can bring to working with older adults. So I think that's our individual responsibility. And again, we'll talk more about that. But then we also have a collective responsibility. I think certainly as a group of social workers, we shape the community of practice in which we practice. So, through our profession, through the respective tables and groups and organizations that we're part of, there is a collective responsibility that we share as well to, to call out ageism when we see it, and then try to reframe that and to challenge it when we see it. Need to acknowledge as well that for all of us, perception creates reality. So consciously or subconsciously, we have ideas about age and about aging, and they're based on a number of different factors that we'll touch on as we go through. But consciously or not, it is in there. And again, as social workers, a big part of our practice is reflecting on our practice and thinking about our own biases. So it can be useful, particularly as you work with older adults, to, I think, really explore that. And we all need to do that on a regular basis. What are my perceptions of aging? What are my biases? And, what can I do with those biases when I do have to work with older adults? Just wanted to paint a little bit of the picture of the population in Newfoundland and Labrador. And studies show that 94.5% of people enjoy stats and presentations, so I thought I'd throw some in. And certainly population aging is not germane to the province of Newfoundland and Labrador. It's a global phenomenon. We're seeing it nationally and internationally. Here in this province in particular, we have a very high rate of individuals who are 65 and older and a very rapidly aging population. So this is just a little snapshot. We can see in approximately the last 20 years, the shifts that have happened in the younger and older cohorts. And then looking ahead to the next 20 years, again, we can see a general decrease in younger cohorts and an increase in the older cohort. And of course, numbers need context. And we talk about perceptions. There are positive and negative interpretations of these numbers. Again, if we're seeing aging as a human success story, and an opportunity for us to thrive in later years as individuals, enjoy good health, explore things that we mightn't have done earlier in life. These numbers can be positive. When we think about the positive impacts of intergenerational activities, the wisdom and knowledge and skills that we can learn from older generations, these numbers aren't that daunting. On the other side of it, though, and I think we need to acknowledge the fact that the dominant narrative, the zeitgeist, is more towards the negative side. So we hear language in the media, in the narrative about the silver tsunami, the aging population crisis. Through COVID, we heard COVID referred to as the boomer remover. So there's lots of language and, I guess, attitude and perception out in the dominant narrative that's very easy to spot, but it can be hard to challenge and to change. So again, numbers paint a picture, and I think for all of us, it's helpful to have sort of that demographic shift snapshot of the area in which we practice and in our communities and our provinces, just to have a sense of how things are changing. I should point out as well, population aging is only one piece of demographic change. We also have immigration, intra-provincial or intra-territorial migration as well. Here in this province in particular, we see a bit of a natural migration out of some of the more rural and remote areas to larger centers. So again, the numbers tell a story. The popular definition or a common definition of ageism certainly is the one that's given to us by the World Health Organization. And it's simply stereotyping and discrimination towards an individual or a group based on age. And we know it can take many forms. It can be attitudes, practices, institutional policies, any practice that perpetuates stereotypical belief. And I'm sure as you think about your own practice, your own different areas or other teams that you work on and clients that you serve, I'm sure if you were asked to, you could come up with examples of individual or systemic ageism. So again, there can be different forms. So we do see ageism that's perpetuated by policies and practices oftentimes, and that's called institutional ageism. Perhaps it's prescribed retirement dates, although we seem to be moving more away from that lately. But any type of policy or program that separates or segregates people based on age. And a lot of times these policies are long-standing. But again, I think as social workers, particularly if we work in the areas of policy, we know how to affect change at different levels in the system. So if we come across those ageist policies or procedures, I think social work is well positioned to ask that question, well, why is it like this? And what could we be doing instead? And what are the steps we need to change it? Interpersonal ageism certainly happens on an individual basis and through different relationships. It can happen within families. Again, it doesn't necessarily always have to be directed towards older adults, but a lot of times it is. And we do see it as well in intergenerational families sometimes. A type of ageism, I think, that's of particular concern and something that we all need to be, I think, aware of and on the lookout for is this notion of internalized ageism. So it's, again, that dominant narrative. If we're exposed to it enough, we actually start to believe the things that we're hearing in the dominant narrative. If we have an anti-aging industry that tells us that getting old is bad and being old is worse, then over time, I think we do start to internalize those messages. And we can see it manifested, and we'll talk a bit about the health impacts and people's experiences of the social determinants of health when they're internalizing ageism. But really, it comes down to, I guess, negative self-talk, can lead to depression, ideas about oneself as less worthy, and it manifests itself in different ways. Like I said, depression, it can manifest itself in older adults maybe not bothering to follow up on things that are troubling them or on medical appointments or seeking help for things, because their sense of self-worth actually changes as they're exposed to that narrative. And I think we need to acknowledge the power of that narrative and the complex task it is to turn that ship around and to change the conversation. The analogy I'll use is it's almost like trying to unsteep a cup of tea, right? I mean, these ideas have been so dominant and so out there for the longest time that we've also almost become complacent with a lot of them. Ageism in particular, I think people are quicker to respond and more intently or intensely to respond to other types of isms, but less so with ageism, I think. We know that ageism can be hostile or benevolent. Sometimes it's very much based in anger. It's fueled by hate, but it has that hostile type of nature to it. Described sometimes as intergenerational angst, anger at other generations because of perception. Why doesn't that person just retire so this younger person can have a job? Why doesn't that old folk, those old folks move out of their house so a younger family can have that? So it can be very, hostile in that way, but it can also be benevolent. It can come from more of a place of ignorance, I think, than hate. And sometimes it can be done with the biggest kind of heart, or with the best, we think we have the person's best interest in mind, but it's really ageist. Again, it can be explicit, it can be very overt, it can be very clear that the person is experiencing discrimination because of age, or it can be more implicit, it can be more passive-aggressive, it can be more subtle, I think, in the ways that it's expressed. And it can be expressed in different ways, and cognitively, effectively, behaviorally. So in the ways that we think about aging, the way we feel, and the actions that we have towards older people. There are different expressions, and certainly a complex ism, like they all are, but important to think about. So again, just wanted to reiterate, and the World Health Organization itself kind of pulls out and underlines this notion of self-directed ageism. So again, it's when individuals project beliefs onto themselves, and over time they actually start to believe those things, right? So it could be that, oh, well, I'm getting older now, can't teach an old dog new tricks. Or, someone in their 20s thinking that they're too young for a job and then not applying. So again, it's not all just about older adults, but it often is in the narrative. And I'd suggest as well, it's something to watch for in clients, but also in ourselves. Because again, we're all aging. We can't deny that. That's how linear time works. But it's important to have that self-reflective piece and, to think about to what extent are those major narratives impacting me personally and as a professional, and how are they impacting the clients that I'm working with. So some perspectives on ageism, and we all have these. One of the ones that's really struck with me over the years and in the reading that I've done is this one from Nelson from 2005, and it's prejudice against our feared future self. And I think that one really encapsulates a lot of the complexity and dynamics of ageism. Because I don't think it's always necessarily about chronological age. There are people in their 80s who are physically healthy as someone in their 30s. I think a lot of times it has to do with the unknown, with the known, because we also know from personal experience, from the literature, that there are multiple changes associated with aging, physical, financial, situational, social, cognitive, across the spectrum. There are multiple changes that come with age. And not all of them we look forward to, because there can be different, experiences of loss that come with age as well. Again, be it socially, in physical ability, cognitive decline, neurocognitive changes, different things in our circumstance, in our employment. A lot of major transitions happen in later life as well. The loss of members of our social circle, retirement from work, and these can be very scary changes. And I think as humans, it's natural to reject and sometimes use humor as a coping mechanism and poke fun of the things that we fear and don't fully understand. So I don't want to say that we come by ageism honestly, but I think it's important to, from a human behavior perspective, think about some of its roots. And I think that can be a helpful piece of knowledge as we think about, how we change or reframe the conversation about aging. A lot of the research on ageism so far has looked at the psychosocial impacts. A lot of concern about population aging and the labor market, because of course there's a lot of focus on the economy and the health of the economy and the labor force and the tax base. This is how our provinces and communities and countries function. So there's been a lot of concern, especially early on, in the terms of loss of labor market force. More recently, it's more about the psychosocial impacts and the human experience of ageism, which is good to see. But there's still that consideration of the labor force piece as well. Another perspective, I wanted to throw this in there. I know the saying is sometimes we can't see the forest for the trees. We can't see the big picture because we're down in the weeds. But I think the inverse is also true. Sometimes we can't see the individual tree for the forest. And in terms of aging, sometimes seniors or older adults are seen as a very homogenous group, or we make sweeping statements about, oh, well, old people like this, or, well, what seniors are like. Oh, well, that's what people in their 20s are like. I mean, we make these assumptions and we use these handles to, to get a handle on things and to understand the world around us. But we do so, I think, at the risk of losing sight of the individual. And the same it is with the aging process. It's to just say, oh, well, that's the aging process. I mean, it's such an individual experience made up of a whole bunch of factors that it's, we lose some of the nuance, we lose some of the picture of the individual in that when we just make these sweeping generalizations. So, important to have the view from 40,000 feet, but also very important, I think, to see the individual and to hear and know the individual and their experience of aging in this particular case. And as we mentioned, ageism can certainly negatively impact our experience of the determinants of health and result in poor health outcomes. So again, we see studies where there's increase in morbidities, comorbidities, actually mortalities and deaths, increased rates of suicide associated with experiences of ageism. So it does have serious impacts. So some of the determinants of health. Of course, these are the range of different factors across the domains that determine our individual experience of health and our population health overall. And these won't be new to anyone, but these are all the various aspects that contribute to our overall health and well-being. And depending on our individual experiences of these determinants, some of which are beyond our control, this will impact how we age and what our experience of that is. So all the more reason to not, I guess, kind of group folks together too quickly and really dig down on an individual level to understand that person's perspective. So depending on the experiences, these negative experiences can really flavor and impact our overall health and our experiences of those determinants. And we know that older adults are at higher risk sometimes of some of these negative experiences of the determinants. Again, we're talking about ageism. So we do know that older adults experience discrimination and exclusion based on age. We do know, particularly through COVID and all the discussion around universal basic income, that a lot of older adults experience poverty. So even, sometimes by our definition or by our market basket measures, by definition, seniors aren't meeting the poverty line, but they're very close. and increased costs, inflation. It doesn't take much to tip people over the line and experience poverty. Inequity, we talked about the trauma, the personal trauma that can be experienced with age or with experiences of ageism. And we do know that older adults are represented with strong numbers in the areas of housing insecurity and food insecurity as well. And ageism is sort of an overlay to all of this. If older adults are experiencing ageism as well, these can interact with or trigger or make worse some of these other negative experiences of the determinants. So some of the impacts of ageism, and again, I'm sure that you folks, if you haven't experienced some of the impacts personally, you've possibly observed them in your families, in your cohort, in your professional practice. But the impacts are very real, and they can be very personal and invasive. I think if a person gets to the point where they've heard negative messages so much that they actually devalue themselves as human beings, I think that's a serious problem. And I would hope that for any of us, if we experience that, or if we saw a client experiencing that, it would be enough of a red flag to know that something needs to be different. So again, we talked about the determinants of health. So definitely poor mental health and physical health outcomes associated with experiences of ageism. It is intersectional in nature as well. A lot of times people experience ageism, but it's not in isolation. So it may also be combined with experiences of discrimination based on race or culture or gender or sexual preference or gender identity, socioeconomic status, a bunch of different things. And then ageism is just another one of the many, lenses of discrimination that gets added to the person. And it can be very complex to pick apart. So oftentimes I think we can't talk about ageism without talking about some of these other pieces as well, because ageism, any ism, doesn't exist in a vacuum. We know that experiences of ageism puts older adults at risk of abuse and violence. I've certainly seen that through my practice with adult protection here in Newfoundland and Labrador. Again, a lot of it exacerbated through COVID, through the social isolation that came with that. A lot of times older adults living with or relying very dependently or solely on alleged sources of abuse or neglect, cut off maybe from normal social activities, be they faith-based or socially, recreationally based. So with that social isolation came the opportunity to, I think, for potential abusers and neglectors to isolate that person, have more control over that person, and I guess perpetuate the abuse. In this province, we certainly saw an increase, we're seeing an increase on the heels of COVID in a number of the reports of abuse and violence against older adults. In this particular jurisdiction, it tends to be mostly neglect and self-neglect, but certainly, again, the experiences of ageism and discrimination puts that older adult at greater risk. There are certainly economic factors. Some of the countries in the Western world have tried to actually quantify what the impact of some of the impacts of ageism are. Recently, the US, I think, put the amount at $60 billion or 60-something billion dollars for the year, just in terms of healthcare costs, lost labor, other types of social programming and supports that have been needed. So there is an economic factor. And again, that self-ageism piece, if older adults are feeling less self-worth, less able or willing or deserving of attaching or reattaching to the workforce, that can have economic impacts as well. It's definitely pervasive across systems. Again, I think if we think about our health and social systems, it's not hard to find very tangible and real examples of either ageist policies or ageist experiences that people have had based on that. And again, I think the impacts can be cognitive, affective, and behavioral. So it can definitely impact the way people think about other older adults, about themselves. It can change the way we feel, and we talked a bit about that. And it can have changes in behavior, the way that we behave towards ourselves and the way that we behave towards other people. So one manifestation of ageism is its related ism, which is paternalism, which is basically the practice mostly on the part of people in a position of authority to restrict the freedom and responsibilities of others in their supposed best interest. And that's kind of an ethically charged statement, and I think very case specific. Are there instances when someone's autonomy should be taken away in their best interest? And it opens up questions about working with older adults with mental health challenges, with dementia through that disease process, raises questions of capacity, autonomy, guardianship of the person. It's a pretty loaded statement. So there's no quick answer to whether or not, are there no instances when it's appropriate? Are there some? I think there are, very strict ethical guidelines that have to be applied to cases where we consider that. In negative ways, and again, this won't be news to folks, but paternalism can manifest itself in different ways. So treating someone like a child, speaking for someone else. I remember being in meetings with families in long-term care, and mom couldn't get a word in edgewise, and trying to engage mom in the conversation and being cut off by the daughters, questions being answered on mom's behalf. And again, not always maliciously, sometimes with the best intention, or, oh, I don't think mom heard that or understood it, not meaning to be mean, but ageist nonetheless. Equating reduced cognition with incompetence. We see this a fair bit. Someone has a diagnosis of dementia. They may be living in long-term care. They have a substitute decision maker. We bypass the adult every time there's a decision or any kind of discussion to be had about something, and we go right to the substitute each time. And it doesn't have to happen like that. Even with reduced cognition, it doesn't mean that the person should be excluded, especially from decisions that impact them. And I think in practice, in the clinical world, in the legal world, thankfully, we're moving away from this concept of competency and moving more towards the notion of decision-specific capacity or decision-making ability. So less of a light switch, more of a dimmer. It's not all or nothing. I think we're recognizing more and more that there's a continuum of capacity. And just because someone has a diagnosis of dementia or lives with an intellectual disability or other mental health issues, it doesn't mean that they can't make decisions in at least some parts of their life. And that's been a shift in practice, and it's been an exciting one. It is an exciting one. And again, through the practice here in Newfoundland and Labrador with adult protection, it's very much a focus in our practice here, that decision-specific piece, and moving away from this notion of global competence. Also, I think sometimes we equate diagnoses with deficits or incompetence or inability, but again, that's not the case. I think a diagnosis or a condition can inform someone's capacity, but it cannot define it, right? And again, capacity is fluid, and we need to be conscious of that. Paternalism can also be manifest by assuming what someone else wants. Oh, well, mom, would definitely want that, or, without asking the person. Now, if you know the person well, sometimes that can be nice and flattering, but sometimes it can be awkward or inappropriate and inaccurate. And the removal of autonomy, of course. And, all of us, I think, we talked earlier about the fear of our future self. I think that's one of the things that we fear when we think about the aging process sometimes, is that loss of independence and removal of autonomy. So again, touched on capacity a little bit. Like we said, it is decision specific. It's about decision-making ability. It's not a binary concept, and it's on a continuum. It can be influenced by a lot of different factors. Health factors, personal factors, environmental factors. It's not something I think that can be assessed or understood in one interview or one assessment. Again, it's not defined by diagnosis or disability, and it's a clinical and legal concept, and it's not a diagnosis. So some of the sources of ageism and paternalism, and we've touched on some of these as we've gone through. Definitely our own individual beliefs and values. And again, consciously or subconsciously, we have these. Not just towards older adults, towards everything. And I think as social workers, we have a unique skill set and ability and opportunity to maybe do more self-reflection than others necessarily would about some of these things. These, metacognitive exercises of thinking about the way we think about some of these things, getting in touch with our biases, and having that level of self-awareness, I think is a great social work skill. But our individual beliefs and values definitely influence the way we think about older adults, for better or for worse. Societal attitudes towards aging, we talked about the dominant narrative in our society, which hopefully is starting to shift, but I think we do have a long way to go. I think particularly during COVID, when there was a scarcity, either real or perceived, of healthcare and other resources, it really kind of, put our back to the wall and begged the question of, what is the value we put on human life? Does inherent dignity and worth have a best before date? I'd like to think not. But again, particularly through COVID, I think we saw some things that really challenged that notion. Another source is lack of formalized training for practitioners on seniors and aging. In a lot of instances in training across disciplines, courses on gerontology or geriatrics or older adults are options. They're not required. I think, more and more we need to think about, we can't remove aging or age from the human experience. We have to think about, the issues that we face are not age issues. They are human experience issues. They're lifespan issues when it comes to having our needs met, having a sense of community, having a sense of social justice and safety. These aren't age related. These are human related. So I think legitimately, and again, it's not from malice, it can be from ignorance. Some individuals who work with older adults have not been properly trained to do so. And there are different approaches that are helpful with working with older adults sometimes. One that I experienced particularly was working with individuals with dementia. It's an approach called validation by Naomi Feil. Particularly fascinating therapy for respectfully entering into the reality of the dementing person. Because again, for all of us, perception creates reality, and the changes that come with dementia, if we're joining with individuals who are moving through that disease process, I think we need to do it in a way that acknowledges and respects their perception of reality. So more training like that, I think, across disciplines is always helpful. Family conflict can definitely fan the flames of ageism, particularly in multi-generational homes. Adults who find themselves in the sandwich generation, maybe with younger children, also looking after older adults, and the very real stress that could cause on family dynamics. Changing roles for family members can also cause, I think, ageist attitudes to happen. So, a person goes from being a child to their parents' contemporary to their caregiver to a visitor in a long-term care home. So, that has to have a toll on an individual, either again, consciously or subconsciously, in terms of their experience in that family dynamic. And also system demands and resources. Sadly, and again, a lot of it was kind of, I think, elucidated through COVID, but certainly existed long before COVID. This whole notion of, clinical efficiencies and movement of people in and out and between and within systems, that's a lot of times dictated by budgets, by staffing, that I guess kind of flies in the face of, to some degree, this notion of person-centered care or resident-centered care. And I think it's easy for us, the royal we as a system, to slip into, budget-centered care or staff-centered care, and that can be a slippery slope. Thankfully, this is a quote from a book that's from the 1950s. It's not recent. It was actually in an old training manual I found for individuals who were going to go into sanatoriums and old people's homes to work with older adults. And a reminder to not treat them as objects for furniture. And I'd like to think that we've come a long way since 1950. Our track record with COVID, particularly in long-term care in Canada, would probably say otherwise. But it's a stark reminder again to me of, what do we perceive as the value of life, particularly in later years. So our perceptions come from, we talked about them before, our experiences and our ideas and our education and everything else. This image has been kicking around for a long, long time, and I just throw it up there just as a bit of a visual reminder that, we perceive people the way we perceive them. And for those who haven't seen this before, it's an image of an older and a younger woman, depending on which angle that you look at it from. I always feel compelled to leave it on the screen for extra time in case people are trying to see both, but not now. So where do our perceptions come from? Again, our own experiences of aging, and they can be positive and negative. Do we have a close relationship with grandparents? Were we born later to older parents? Do we have a large cohort? All of these different factors will flavor our perception of age and aging, and also our health. I think, if we're healthy, again, the chronological age matters less. Advertising, again, we talked about the dominant narrative out there, the jokes that we see on TV and movies and birthday cards. We have a whole age-defying industry, which to me just defies logic, not age. But it's, all of these things, set the tone and give the message that, getting old is not necessarily a good thing. Again, our own family life and family dynamics, societal norms, and the culture in which we grew up and we were indoctrinated, our own beliefs about end of life, what happens towards the end of life, what happens after life, a lack of understanding, and again, some fear. So some policy responses to ageism, and there will be some, again, international, national, provincial examples here. And I would encourage you to look around your jurisdiction as well to see what's happening at different levels of policy in terms of responses to ageism. And we'll touch on some of these, the United Nations Decade on Healthy Aging, the Age-Friendly Communities movement. Here in Newfoundland and Labrador, we're working on a new social and economic well-being plan with a focus on the social determinants of health. We just completed, and the first report has just dropped to government on a new health accord for the province, which has been a massive undertaking and a major revisioning of the way that social and health programs are delivered in the province. Probably the biggest proposed shift in our systems for the last 40 years. And it lays out a 10-year health accord for a shift to more primary healthcare and preventative care. Legislatively, again, in the province, I'll touch on some of these. And your jurisdiction would, I would think, have comparable pieces of legislation that dictate or influence policy and practice, and definitely worthwhile being aware of those. So I'll just touch on some of these. So again, the UN Decade on Healthy Aging, and I love their language here, 4 action areas and 4 enablers with older people at the center. I'm reminded of the saying that comes from the disability community, nothing about us without us. And I think we all feel that way. So the 4 pillars of the UN Decade on Healthy Aging, it's changing the way we think, feel, and act towards aging, cultivating age-friendly environments, and we'll talk a bit about that, creating integrated and responsive healthcare systems and services. So again, creating, I guess, more health equity across the lifespan, and ensuring access to long-term care for older people who need it. I've also included links to a lot of these things at the end of the deck, and definitely worth checking out as well, doing some more research. Age-friendly community. So this is an international movement that was initiated, again, by the World Health Organization back in 2006. It landed in Canada in 2007 as a pilot. There were a couple of communities here in Newfoundland and Labrador, actually, that participated in that pilot. And here in this jurisdiction, it kind of got off the ground as a program in 2009. But it's an age-friendly community, looks at the physical and social environments and how those are designed to support and enable people to enjoy secure environment, good health, and to age in a positive way across the lifespan. So here are the 8 domains across those social and physical domains that Age-Friendly considers. And your community may already be involved with Age-Friendly, and we'll talk a little bit more about how to get involved with that as we go through. Just a little note again, this is an initiative in Newfoundland and Labrador. It's part of our minister's mandate to create a new social and economic well-being plan for the province, and kind of, I guess, revision the way that we address poverty. So it has a number of objectives that you can see here. And again, very much that lifespan approach. How do you set people up early for success, but then how do you also support them across the lifespan to have as optimal health as they can? I mentioned Health Accord NL. So it's really, again, taking a very hard focus on the social determinants of health. And what we found is, in this jurisdiction, we're spending the most per capita on healthcare, but have among the worst, if not the worst, health outcomes across different domains. So it isn't always a matter of spending more money. It's how that money is spent and how services are delivered. So again, it's how do we rebalance the system. I mentioned this, it's the biggest change in 40 years. 40 years ago, our system was designed for a very different demographic makeup than we have now. We've basically inverted the population pyramid in terms of younger adults to older adults in the province, and our systems have not really kept pace with that change. The Accessibility Act is a newer piece of legislation in the province in the spirit of the Accessible Canada Act, and a number of other jurisdictions also have this type of legislation. It's enabling legislation, which basically means it gives the government the ability and permission to create standards. So we have established an Accessibility Standards Advisory Board of citizens from throughout the province who will help actually develop these standards in various areas, again, across that social and physical domains to remove barriers to inclusion. Adult protection, again, that's the other hat that I wear. It's the law in our province that protects residents who are at risk of abuse, neglect, or self-neglect, who do not understand or appreciate that risk. And that's the kicker with adult protection. It's narrow in focus. We know, sadly, that the realities are that abuse, neglect, and self-neglect are very broad, very large social issues. The Adult Protection Act here only applies where we've established that the person doesn't understand or appreciate the risk. So it still leaves, those who do understand and appreciate the risk, having to seek other options. It's the legislative authority in the province for delivery of services to those adults, and there is a duty to report as well. And again, we talked a bit about this. The focus in adult protection is on decision-specific capacity. So we're not out to say the person is globally incompetent. It's what is the specific decision or decisions that are causing some concern. They could exist in any or multiple of these domains that are in red here on the screen. and how do we assess to and care plan for and support the person in those domains where they don't have the capacity. So, and even within these domains, I should mention that, again, there's a continuum of simple to complex decisions. So it's even not accurate to say, well, this person can't make any of their financial decisions. Again, that's a bit sweeping, and it may not be accurate based on the person's capacity. Advanced care planning, I wanted to mention, and I would think each jurisdiction has its own version of this. And really, I think it has a tool, it has a role in minimizing ageism, because it's ways for all of us to have our say when we're no longer able to speak for ourselves. So it's important that I think people have an understanding of what these different documents are and what they can do. And the important thing we try to emphasize in education and conversations about these things is the last point there. So you don't have to have any of these things, right? They're tools, they're options. But I think when we want people to make an informed decision, they need information. So they need to know the implications of deciding with these documents or the lack of a decision. What happens if I don't have any of these things in place? So, because then there are other legislative and mechanisms that kick in to make decisions on people's behalf. And sometimes when people know that, they have an increased interest in having an active role. So we talked a bit at the beginning about individual and collective responsibility. So what are some of the opportunities? And this is not an exhaustive list. And again, I think as social workers, as clinicians, as citizens, we need to look around and say, what are the opportunities I have to, be part of conversations about healthy aging, that combat ageism and reframe the discussion. So these are just some examples, again, nationally and closer to home. So there is a National Seniors Council in Canada. In our province, we have an advisory council on aging and seniors throughout all of our communities. There are public consultations and town halls that happen. The federal government recently undertook an exercise on ageism, actually reached out across the country, did consultation sessions. So there are opportunities, again, personally and professionally, to have input into these and to bring a social work perspective of social justice and equity to some of these opportunities. Age-friendly communities, again, it's international, it's national. There's certainly a lot of examples throughout Canada of age-friendly communities. It's very much supported and endorsed by the Public Health Agency of Canada and by a lot of provincial governments. Municipal governments play a leadership role. So I think, if your community isn't already engaged in the program, great opportunity to actually get in there and to be a part of. If it hasn't taken off in your community yet, there may be an opportunity to have a conversation with your council or with your municipal leaders or with your 50 plus club or other community groups about, is this something that we should undertake? And I can't really say enough positive about the Age-Friendly Communities program. There's a really robust assessment that's been developed. It's a great tool for sparking conversation at the community level, which really is where it needs to happen. What's the capacity? What's the interest? If we as citizens of this community want to live here for as long as we want to, what does that need to look like for me as an individual? What does that need to look like for us as a community? So it's a great tool to help facilitate some of those conversations. In our province, and again, similar in other jurisdictions, I'm sure there's an umbrella group of 50 plus clubs and seniors groups that represent in this province over 7,000 individuals who are 50 plus. They're very kind of recreationally focused, but also meet annually to talk about social issues, put forward suggestions to government in terms of social health policy ideas, and very collaboratively and respectfully advocate for change. We've got a great provincial organization in the province called Seniors NL that has a provincial reach and does a lot of work around information and referral and system navigation with older adults. and those who support them. We're lucky as well to have a volunteer group of older workers NL who are really looking at some of those barriers and opportunities for older adults to either stay connected or reconnect to the labor force. And there's a lot of good advocacy work happening there with that group and through the Office of the Seniors Advocate in Newfoundland and Labrador. We're lucky in the province as well, and I imagine in some way, shape, or form you have this too. We have a universal design network in the province. That's an interagency group that really looks at opportunities to apply those 7 principles of universal design, again, across that physical and social environment to the design from everything to buildings, to websites, to customer experiences. And I think that whole concept of universal design, or the principles of universal design, will very much be influencing the work of the Accessibility Standards Advisory Board I talked about earlier when we look at developing accessibility standards in the province. I always add, so there's 7 principles of universal design. I always think the other 2 should be dignity and kindness. And I think if we were universally applying dignity and kindness, well, one, a lot of us would be out of a job. But I think we'd see, a lot of lessening of our social ills, certainly less isms, less ageism, if that dignity and kindness was extended in more circumstances. And again, as individuals, as clinicians, as citizens, as humans, we have to ask ourselves, what is my sphere of influence? Right? So who are the groups I'm meeting with? Who am I talking to? What tables am I at? That would allow me or give me the opportunity to be a part of reframing some of these conversations. So some of the things that we can do, again, as individuals, and we've touched on some of these, I think we need to be self-aware. And as social workers, that's built right into the gig. We have a professional responsibility to be aware of our biases, to reflect on our practice, to think about our competencies. So being self-aware when it comes to working with older adults, I think is a given for social work, but it's something I think we should take advantage of. I think we need to normalize the process of aging. Chronology is not a disease. You're never going to see aging written on a medical alert bracelet, right? So I think we need to normalize the process of aging and age itself, and try to find more of those commonalities. I think we need to create safe and inclusive spaces, particularly in an intergenerational way. So again, a lot of evidence in the literature to support the fact that intergenerational activities, quality interactions between generations goes a long way to reducing that stigma and minimizing ageism. I think we need to use language consciously and carefully, and I think social workers are very good at that. We need to ask and we need to listen. I think we need to listen to understand versus listening to respond, and really getting to know the other person's perspective. And again, I think social workers are very good at that. We're good listeners, we're good communicators, we're active listeners, we're reflective listeners. So we're good at getting to know people. And I think we need to do that, particularly with older adults. We need to inform ourselves and others about, I think, instances of ageism and opportunities to change that. We need to support and validate people who are experiencing ageism, whether they know it or not, who are experiencing age-related changes, and either in an anticipatory way or actively, and just really validate those experiences. And we need to live the platinum rule. So the golden rule says treat other people the way you want to be treated, and the platinum rule says treat other people the way they want to be treated. So I think that means getting to know the person. And again, as social workers, we get to know our clients. And all relationships take time and effort, and it's no different with the therapeutic relationship. And we know ourselves that the better we know that client, the richer that interaction. Some of the things we cannot do, I would suggest, we can't decide for the other person, impose our values and risks, tolerances. People are going to live the way they want to live. We all want that right. I don't want anyone coming along to me and saying, you can't make that decision anymore, or you can't do that. None of us want that to happen. So it's important to know what our risk tolerances are. We can't dismiss others' values and wishes, or other people's dignity and worth, and other people's right to live at risk. We all have the right to make bad decisions, thankfully, because I've made a few, but we can't minimize that or take it away from folks. And we also can't lose sight of our desire to maintain control over our own lives for as long as possible. All the more reason to have those conversations again about advanced care planning. So just some final thoughts before I pass it back to Annette. And again, I hope none of these are startling revelations for social workers. We know this, we live it every day, we practice it. But each person has a story, and that doesn't change as we age. And I think we have an opportunity to keep listening to those stories. Relationships do take time. People are experts in their own lives. We are all presumed as adults to have full capacity unless it's proven otherwise. We all want the right to live the life of our own choosing. We want choice and control. Information about everything we discussed today is readily available. Like, there's so much material out there on this stuff. There's no lack of opportunity or materials to equip ourselves with knowledge about different perspectives on ageism. And again, I think we need to remember that platinum rule, what it means for actually getting to know that other person, and those skills of active listening and empathy. I also included just some links to a lot of the stuff that I've been talking about today, and those will be available. Even more links, so lots and lots of links in case, as social workers, we're often stuck for something to read. So it's helpful to share this information too, I think. And these are my coordinates here, and I would love to hear from folks about any of your perspectives or initiatives that you're looking at around ageism. Again, I think in this province, we're soon going to be looking at a public awareness campaign around ageism and age-friendly communities. I'd love to hear your thoughts or experiences of any of that as well. So I'll stop there. I'm so grateful for the opportunity to have done this, and look forward to your questions. Annette, I'll pass it back to you.
Hi, Henry. That was a wonderful presentation. Thank you so much. So we have arrived at our question and answer period. We have some questions and comments that have been coming in. This is one comment that came in, Henry, earlier on that you might want to address, but it is ageism is the only ageism we all go through at some point in our lives, realistically. I thought that was an interesting comment based on what you were talking about as well in terms of age, discrimination on any age.
That is a great comment. Yeah, excellent. Thank you.
Someone else noted when you were talking about internalized ageism that they noticed women do this very early on in life, especially in light of the beauty industry. That was another.
Absolutely. Yeah. And that intersectional nature then, right? So it's gender and ageism, but yeah, absolutely. The anti-aging industry is fascinating.
Mm-hmm. Yeah. So another question that's come in terms of, I guess, if we're working with people and the impact of internalized ageism, what are some of the warning signs that we should be looking out for as social workers?
So, I mean, I think it manifests itself in different ways depending on the individual. But I mean, some of the red flags are, certainly changes in behavior, signs of depression, a change in that person's narrative. They're not prioritizing self-care as much. Maybe they're missing appointments. Maybe, they're making comments that suggest that they're devaluing themselves. So, and again, I think the better we know the clients, the more we can see, because sometimes there's subtle changes. But, the way that we value ourselves, that, we wear that, it's out facing. So if that feeling towards ourselves is changing over time, that's going to be manifest in subtle or sometimes obvious ways that we need to watch for. But those are some of the ways, I think.
Mm-hmm. Yep. Excellent. Thank you. Another question that's come in is, I guess, a future type question is, where are we going and how are we creating and contributing to new ways of positively viewing and creating structures for healthy aging any reflections that you might have on this?
Yeah, I think, there are government initiatives, social policies, and programs that, especially post-COVID, have kind of, I guess, reset the conversation a little bit and made us understand that the way we've been looking at a lot of these things is no longer acceptable. So, I think through policy initiatives like age-friendly communities, things that, build capacity at the community level, inclusion exercises, intergenerational exercises, anything that kind of, I guess, breaks down that concept of other and that, increases our exposure to one another and understanding across cohorts is positive. So, post-COVID, I'm a bit optimistic that, the change in conversation you're seeing at all levels of government and through, community organizations about the way things, what needs to come next. So I think that's an encouraging conversation, and it's an encouraging moment when a lot of these conversations are starting to align, I think.
Mm-hmm. Yeah, excellent. Thank you. So in terms of another question that's come in around the internalized ageism, how can we best, as social workers, support and provide services to people who are experiencing ageism?
That can be complex because if it's an individual experience, depending on what's the cause of the ageism, it might be challenging. If it's a policy or program that we can't necessarily change, how do we work with our clients to equip them to advocate for themselves? But if it's, it depends on, I guess, how it's being manifested. But it's important, first and foremost, to, I think, give voice to the person's experience of ageism and help them to think about solutions and how they might be able to advocate for themselves.
Mm-hmm. Thank you. And this is kind of related to this question in terms of, a policy or an institutional policy that that may be difficult to change, or maybe there's some room to inform those policies. But someone's asking about a particular, a new bed policy, and if that will be an example of paternalism. And in that jurisdiction, the policy or law is more that, people are moved from hospital into long-term care when available, and, limiting or removing that individual family's choice of where their loved one ends up. And how would you see that in terms of this discussion this afternoon?
Yeah, it's a challenging issue, and I think it's the intersection between individual right, individual choice, and the system reality, right? So, like, what is the clinical need? Where does the person need to go, and where is that service available? Because we always talk about the right service in the right place. But at the same time, I think first available bed policies sometimes do usurp people's choices. And understandably, I know it's done for the reason of clinical efficiencies and whatnot. But, I think there's a way to reframe or rethink some of those policies to keep the human element in there a little bit more. We know, especially with dementia, with individuals experiencing dementia, this whole notion of multi-transfer trauma and first available bed, your bed of choice, and moving folks around can have serious detrimental effects. So it's much easier said than done, but I think decision makers and policy makers, we need to think about, like, where is that sweet spot between operational requirements and the human experience of those policies. So I don't know if that's much of an answer, but it's a complex issue.
Yeah, no, it's a really good answer, and looking at the balance of all those different needs and perspectives, for sure. Another question that's come in that this person notes that they hear a lot of seniors talking about the golden years, but that they actually feel that there's no such thing. How do you think about this in terms of ageism, or perhaps internalized ageism as well?
Yeah, I think some of it is internalized ageism. And again, I think it gets back to those experiences of the social determinants of health and the experiences of the natural and sometimes unnatural losses that come with getting older. I think, sometimes we minimize or we don't think enough about the grief process as well that comes with aging. Like, we think about grief and loss with death, but we grieve in different ways in response to multiple losses. So like sometimes, and I can understand that the golden years may not seem as golden. If you've lost most of your cohort, there's changes in your abilities or your needs. So I think a lot of it just comes down to, your experience of the determinants of health and your own health. And sometimes that's regardless of age. But I think it's also an opportunity to get at with that person, is there an opportunity to kind of help reframe for them where they're at, and the reality of their situation, but also the opportunities that may still exist in their situation for some quality of life. And we can't make assumptions based on age. Well, your quality of life would improve if you did X. Again, I think it comes back to having a conversation with that person, understanding their experience of the losses, and then hopefully building on strengths to kind of bring them back a little bit to, help them make a choice about maybe having a bit of a healthier experience.
Mm-hmm. Yeah, excellent. Thank you. This question is pertaining to policy development, and in terms of, even from your perspective in interdepartmental conversations, and is that happening in terms of, the impact in one department and looking at ageism across departments? Is that something that's been happening?
I think it's happening more and more. And I think, again, COVID has really been an impetus for that conversation. And, we beat ourselves up about silos, but, we're educated in silos, we live in silos, we work in silos a lot. So we have to very actively and consciously, work to overcome those. I know here in Newfoundland and Labrador, one of the responses to COVID when the pandemic first hit was the creation of a vulnerable populations task group. And that was interagency. It was community. It was volunteer. It was folks with lived experience. It was government. About 100 people on a regular basis at the table talking about, how COVID was impacting different parts of, the population of the province. And a lot of working groups came out of that. Interagency tables have kind of spawned from that, and those are continuing. So I think that's positive. There's a saying that there's no ill wind that doesn't blow someone a bit of good. And I think, out of the tragic events of COVID have come some of these opportunities forced and, sometimes facilitated ourselves to do things differently. So, and I'm really encouraged, again, here in Newfoundland and Labrador, we've recently established a cabinet committee on seniors. So that's an interdepartmental exercise within government. But yeah, I think, departments or other groups really need to see themselves like we all have a vested interest here. Again, if we're not seniors yet, hopefully we will be, but we're all aging. So, just like we need to consider gender and all of these things, we need to consider rural, remote, and geography and culture. We have to consider that age piece as well. So it's that collective responsibility part. So I'm more optimistic recently than I have been about some of those collaborations.
Excellent, thank you. We did just get a couple questions around the resources that you shared. So I just wanted to let people know that the PDF of Henry's PowerPoint presentation with those slides and resources are in the resource section on the webinar platform. So you can just go in there and grab that document, and then you'll get the resources from there. Another question that's come in, Henry, is you talked about the principles of universal design, and someone's wondering if you can give a brief overview of those 7 principles, because it was a new concept that they just hadn't heard of before.
Yeah, I mean, basically it's the idea that everything would be as usable as possible for the most people possible. So there's actually 7, and I don't know all of them off by heart, I'm afraid, but I can give you some examples. Let me see. Yeah, no, I can't find them. I will look them up though. But essentially, it's if you're designing or redesigning something in the physical or the social environment, how can it be used by the most people possible? So a good natural example would be the design of an airport, for example. So it's not necessarily overtly like, let's design this for people with disabilities. It was just designed with wide doors sidewalk entrance with no particular consideration given to any one group, but it's just made for the most people possible.
Mhm.
I will look them up, and we can put a link to them in the resources as well.
Perfect. Thanks, Henry. Getting back to the policy development and planning, have you seen many considerations regarding the intersections of ageism and with the other ageisms, or isms, sorry, in policy development and planning?
I have, and again, the example I gave from this province is the recently completed health accord. So a lot of talk in there about the social determinants of health, but across the human experience. So regardless of age, ability, income, geography, other things that we use to define ourselves, we all want those basic things and those experiences of health. So yeah, I think the more focus that we're seeing now on those social determinants of health, the healthier and the more positive social policy I think we'll be able to create.
Mm-hmm. Well,
and I need to double back. I felt bad I didn't have them a quick reference, but the principles of universal design, just a couple of examples. It's around, again, the most usable by the most people, flexibility in use, perceptible information, low physical effort, appropriate size and space, designed for equitable use, basically, is the thrust of universal design.
Excellent. Thank you, Henry. Another question is more around, our own personal, check-ins. Any advice on how we can keep checking in with ourselves about our own thoughts and beliefs about some of these concepts around ageism and those isms that can present?
I think self-reflection is a skill that we develop over time, and I'm certainly still working on my skill of self-reflection. But again, I think some of those, metacognitive exercises, thinking about the way that we think, engaging in some paradoxical analysis with ourselves sometimes is useful. Like, I believe A, but what if I believed B? And kind of argue and try to understand the other perspective. I think also reading information or exposing ourselves to information that we don't necessarily initially agree with. Because over time it's easy to develop that confirmation bias, and we just look for things and draw things to ourselves that support what we already think and believe. So I think it's purposefully going out of our way sometimes to find the counter argument, even if it's not to agree with it. It's at least to understand it, but also then being open to to being wrong. And I think we need to be open to that, to objectively taking conflicting information, weighing it out, and deciding whether or not we need to change our own beliefs. But easier said than done, and it's definitely a lifelong practice, I think.
Mm-hmm. Yeah, for sure. So we still have some questions coming in, and we still have some time. So if you do have any additional questions, let us know and type it in the question mark widget again. In terms of I guess on the heels of the self-reflection question, what do you think stops people from intervening when they see instances of ageism?
I think sometimes it's our perception that ageism is not a big deal. But if I think we have decent radar for that, particularly as social workers, like if something seems untoward or sounds wrong. But I think a lot of times we do minimize it because we don't necessarily either recognize it or think that it's a big deal. And maybe there are other reasons, but I think that's probably one of the primary reasons. Although another one worth noting, I think sometimes, is family dynamics. So we may be working with an older adult, and the example I gave earlier, like very forceful family or overbearing family, and it's hard to hear from mom or dad, or it's hard to engage them without interference from the other. So sometimes, depending on how willing or able we are to kind of wrestle with that dynamic and make sure that person is heard, which again requires a lot of thoughtful social work skill, I think. It can be not easy, but it can be possible to just kind of gloss over and keep moving.
Mm-hmm.
Yeah.
Okay, great. Thank you. Someone else is just wondering, in terms of what can agencies, like possibly like a seniors advocate or, other agencies that are providing services to older adults, what can they be doing or looking at to address the needs of older adults? Or what are they currently doing to address the needs of older adults?
I think a lot of organizations are doing it well. The most important part is engaging. We talk about people with lived experience. Now, we all have lived experience of aging, but it's, engaging the people who are using the service, who are part of the service. It's the classic social work question: what's working well and what could we be doing differently to make this better? But always kind of having that dialogue open. And sometimes we assume if we haven't, if something's not gone off the rails, we just assume that the policies and programs are fine. But it's, I think, creating those spaces and opportunities for people to have that feedback, making it as didactic as possible to say, like, are we getting this right? And is this meeting your need? Also, I think organizations can, do that self-reflection piece themselves. The materials that are public facing, in our policies, our public image, is there anything in there that's ageist or has ageist assumptions? Is there anything that we can do? There's lots of examples out there about age positive language, age friendly language, so kind of doing that self-reflection piece to see, how they're doing. But I think a lot of organizations don't give themselves enough credit sometimes. And, even with the age friendly piece, communities worry that they're not doing anything. I think everywhere there's something happening that's engaging older adults, but is how do we do it in a more deliberate and consistent way, I guess.
Yeah. Excellent. Thank you. The next comment came from the chat, or question came from the chat, group chat, but and I guess it relates to the discussion we were having around paternalism. So if you're working, for example, this person works with a homeless population and have, a lot of individuals who are aging, and in terms of having that conversation around supportive housing and long-term care, with people who may not be interested in hearing some of that. Any feedback that you want to provide?
That can be really difficult. And, all of us, we all have the right to refuse service. But we also all have the right to make informed decisions. And I think, social workers have a role to play then in, again, if we're expecting people to make informed decisions, they need information. So, what are the risks that we're seeing with clients? How overt are we being about that? Are we finding ways to provide them with information so they can make informed decisions, including the implications of a lack of a decision? But, until or unless we go down the road of, questioning someone's capacity and they're at risk and they might not be able to make that decision anymore, a lot of it is, being able to step back and respect the decisions, good and bad, that our clients make. And that's difficult to do sometimes.
Yep, absolutely. Thank you. This is just another comment that's come in. We need to remember that ageism applies to youth too. With all these folks aging, retiring, needing help, we need to be realistic in supporting and encouraging youth to step up and to get civically engaged, which is what goes back to your initial point, Henry, that age is across the spectrum, right? And having that conversation.
Yeah, heard a great one the other day that actually came from a senior. So that young crowd, so they don't even want to work anymore. That's an ageist statement. And it's a presumption about a whole generation or a whole cohort of people, based on one or two experiences of that person. So,
so it's a good conversation to be having across the spectrum.
And all the more reason and the more benefit in those intergenerational activities, right? And some of them are naturally occurring, like even here in the province, we have a long-term care facility that has a daycare built in. But it's, looking for, I think, those natural opportunities to expose generations to each other. Is it skill sharing? Is it whatever? And again, the literature and examples will tell us, though, that the interactions have to be meaningful. And a lot of times I think they're done with good intentions, but they're not always meaningful interactions. Like, bringing a choir into a group, like just not having interactions between, groups. We need to think about the quality of the interaction.
Yeah, and that leads into a question that did come through in the question section. Is if do you know of any funding, grants, or initiatives that are promoting intergenerational programming that are meaningful?
So I do know nationally that the New Horizons for Seniors program does contemplate those types of projects. In Newfoundland and Labrador, we have a program called the Seniors Social Inclusion Initiative, which just rolls off the tongue. But that has a very deliberate focus on intergenerational programs as well. And I will mention and put a plug in, another part of our minister's mandate is to actually develop a provincial guide to intergenerational programs. So we're in the process now of getting ready to do some consultation with some different groups across the lifespan about what that needs to look like. So I think there's more and more recognition and more evidence in the literature to support the value of these intergenerational things. So I think more programs are kind of starting to lean that way. So it was definitely worthwhile looking around your own jurisdiction as well to see what the options are. And even if it doesn't explicitly say for intergenerational activities, a lot of times you can just do intergenerational activities with the funds that you get from these different grants.
Mm-hmm. Yeah, absolutely. So I know we're nearing our end of time, and thank you for everyone who sent in your questions. And I don't know if we had time to get through all of them, but I tried to theme them as they were coming in. So and Henry did a great job of hearing all those questions and providing some insight and perspective. Henry, did you have any concluding comments that you want to make in terms of a wrap up from the question and answer period before we finish?
Just to say thank you very much again for the opportunity and the obvious interest. You know, it's an area, again, that impacts all of our areas of practice. So valuable, I think, to have opportunities like this to reflect and to have conversation about, you know, what aging means to us and how the whole aging process and ageism appears in our relative areas of practice. So yeah, just leave people with that idea of the individual and collective responsibility to keep the conversation going.
Excellent. Thank you, Henry. And from some of the comments that were coming in, people certainly found this very helpful today in terms of starting that conversation and continuing with that reflection and that conversation and discussion that needs to keep happening if we're going to address ageism and how we're going to do that, right? So thank you so much for sharing with us today and for facilitating this stellar webinar and for sharing your experience, your knowledge, and your perspective on this very important topic of ageism and what individual and collective actions that we need to engage in to address this in our practices, but in our workplaces and in our communities. So it is a big conversation that we need to be having. And for everyone who attended, we hope that you do take some time to reflect on, you know, the session today and how you can be part of changing the conversation about aging and ageism. And this is certainly within line with our code of ethics and in our efforts to ensure a socially just and inclusive society. So Henry, thank you for taking time from your busy schedule and the important work that you do and for facilitating this session for us today and for making it national during National Social Work Month. So thank you for that. It is truly appreciated. RSWs in Newfoundland and Labrador may claim 1.5 required CPE credits for attending the webinar as per our policy. And for those of you joining us from around the country, please check with your regulatory body on how you can claim this session and download the certificate of attendance if it's required. Again, the PowerPoint presentation is available in the handout section on the webinar platform. So there you'll find those slides with those important resources and links that Henry shared. And as you begin to sign off, we also ask that you complete the evaluation form that will appear on your screen because your feedback is always so helpful in terms of helping us plan future sessions. So on that note, I just want to say thanks again to Henry and thank you all for joining us from across Canada. And we hope you enjoy the rest of your day and the remaining Social Work Month activities and events. So thank you, everyone.